morning, everyone, and welcome to today's webinar presentation, From Breast to Best to Fed is Best, a trauma and violence-informed approach to caring for and supporting women and families with infant feeding. My name is Sarah Carsley. I am an applied public health science specialist at Public Health Ontario, and I have the pleasure of co-moderating today's session. Before we begin with today's presentation, I would like to acknowledge that I'm in Toronto, on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. I also acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaties signed with multiple Mississaugas and Chippewa bands. I'll now mention a few housekeeping items. To enhance the presentation experience, participant audio video has been disabled. The chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have questions during the session. A discussion and question period will follow the presentation. If at any point during the session you experience any technical issues, please email capacitybuilding@oahpp.ca. I would now like to introduce my co-moderator for today, Dr. Karen Campbell. Dr. Campbell is an assistant professor in the School of Nursing at York University. Her doctoral and postdoctoral programs of research involve public health nursing interventions to support women's health. Currently, Dr. Campbell is investigating the experiences of trans men and non-binary people while they provide human milk feeding to their infants. Her clinical background is as a public health nurse, where she spent 17 years practicing in family health programs, including breastfeeding support, Healthy Babies, Healthy Children, and the Canadian Pre- and Postnatal Nutrition Program. Karen has also been a volunteer breastfeeding supporter as a La Leche League leader for almost 20 years. Over to you, Karen.
Thank you, Sarah. I'm thrilled to be here today co-moderating with you and representing the work of PHN Prep and our team in supporting PHN supervisors, managers, and home visiting staff in the work that they do with families. Today's presentation will describe how public health nurses and other community-based professionals can integrate a trauma and violence-informed approach to care when interacting with and supporting women and families in their choices around infant feeding. It's now my pleasure to introduce the speakers for today's presentation, Dr. Kimberly Jackson and Dr. Tara Mantler. Dr. Jackson is an assistant professor at the Arthur Labatt Family School of Nursing at Western University. She's the co-lead for Women's Health Matters. Dr. Jackson's program of research is focused on improving health outcomes for women and their children, with a particular focus on nursing care in the antenatal, interpartum, and postpartum periods to provide trauma and violence-informed approaches to access and address breastfeeding and perinatal pain and mental health. Dr. Mantler is an assistant professor at the School of Health Studies at Western University and is also a co-lead for the Women's Health Matters program. Dr. Mantler's program of research centers around health equity research, specializing in gender-based violence, women's health, and the adoption and integration of trauma and violence-informed care principles into practice and policy. I'm going to pass it over to you, Tara and Kim.
Thanks so much for having us. We're excited to be here and thankful for your warm introduction, Karen. As Karen mentioned, the purpose of this webinar is to describe how public health nurses and other community-based professionals can integrate TVIC approaches and principles when interacting with and supporting women as well as their families in choices around infant feeding.
Thank you, Tara. So just before we get started today, we thought it would be important to go through some disclosures, disclaimers, and our positionality. So first and foremost, neither Tara nor I have any conflicts of interest to declare. And while we're not aligned, we are not aligned with any organizations that promote any one type of infant feeding. So while we've offered kind of a catchy phrase for this title of the presentation, we are not now, nor have we ever been, affiliated with the Fed is Best Foundation. And we actually didn't even know it was a foundation until somebody graciously brought this forward to our attention. So we also thought it was important up front to help you understand our positionality. Tara and I are well-established researchers in the spaces of women's health, gender-based violence, and breastfeeding. So just as an example, we've published work on breastfeeding-related pain and postpartum support of breastfeeding mothers who are at risk, to name a few. Our research is primarily equity focused, so we have a specific emphasis on how to support those who are feeding infants in ways that work best for their families, in alignment with person-centered and trauma violence-informed care approaches. So specifically, we're committed to helping ensure that families have what they need, that they have choices, and that these choices are safe and informed so that they can feed in according to their needs. In addition, we wanted to make it clear up front that this webinar is in no way a critique of breastfeeding or breastfeeding promotion efforts, and nor are we weighing in on the breast versus bottle debates, nor are we making any claims about the importance of breastfeeding for mothers, infants, or families. We wanted to mention a few things about language in this webinar. So first, we will be using the word mothers, as mothers may identify with a wide variety of genders. So the term mother is meant to include all. And while it's imperfect, because there is no clear consensus on a completely inclusive term, we will be using the word breastfeeding to refer to lactation by a mother. And finally, because we're going to be talking about some potentially distressing topics in this webinar, such as trauma, gender-based violence, and intimate partner violence, we encourage you to take the necessary steps for your emotional safety, whatever that may be, which may include leaving this webinar. Over to you, Tara.
Thanks. So moving into the webinar, there are 4 parts. I always like a roadmap at the start of one of these to sort of get my head around where it is that we're going. So first, we're going to provide some background on BAFHIs. Next, a discussion on breastfeeding support and gaps in care. And then we're going to look at TVIC and apply it to infant feeding support. And finally, we'll have a time for some questions. When we look at breastfeeding, it's important to consider the history so that we know where we have come from and how far we have gone. By way of a bit of history, in the 1970s, only 35% of infants were breastfed during the first week of life. And by 6 months, only 6% were still breastfed. This largely had to do with a cultural shift towards formula, with formula being widely accepted as an optimum feeding option for mothers in the 70s who struggled with any aspect of breastfeeding, leading to a generational loss of knowledge in breastfeeding. As a result, there were many public health initiatives that were launched, including Breast is Best and Baby Friendly Hospital Initiatives, or BFHIs, to name a few. When I think about the effectiveness of campaigns, it's in its totality. Breast is Best was one campaign, but there really were a series of campaigns, various health promotion campaigns that were done in order to improve breastfeeding rates. So these campaigns included Breast is Best and the BFHI, which was launched in 1991 in partnership between the World Health Organization and the United Nations International Children's Emergency Fund. And by the early 90s, the number of Canadian women who were initiating breastfeeding had risen to 75%. BFHI is a global initiative designed to help motivate facilities in providing maternity and newborn services worldwide to implement the 10 steps to successful breastfeeding. These steps include both critical management procedures, like having a written infant feeding policy and ensuring that staff have knowledge, competence, and skills to support breastfeeding, as well as clinical practice initiatives, such as discussing the importance and management of breastfeeding with pregnant women and their families, supporting mothers to initiate and maintain breastfeeding and manage common difficulties, enabling mothers and their infants to remain together and to practice rooming in 24 hours a day, and counseling mothers on the use and risks of feeding bottles, teats, and pacifiers, to name a few. There is substantial evidence that implementing the 10 steps significantly improves breastfeeding rates. A systematic review of 58 studies on maternity and newborn care published in 2016 demonstrated clearly that adherence to the 10 steps impacts early initiation of breastfeeding immediately after birth, exclusive breastfeeding, and total duration of breastfeeding. And currently 91% of mothers initiate breastfeeding in Canada, and specifically 92.1% in Ontario. So we're a little bit higher. These health promotion and education campaigns have helped to normalize breastfeeding and breastfeeding in public, as well as empowering women to pump out work, all of which are worthy of celebration. However, and I think we probably all saw the however coming, these campaigns and initiatives are not without criticism, and these criticisms largely center around the rigidity of these policies. Specifically, Bass and colleagues in 2016 reported on how these 10 steps could potentially be unsupportive of parents' emotional and physical needs, notably the concern against pacifier use, which is protective against SIDS, and the 24-hour rooming in when patients may still be in a sedated state post-delivery. Further, a 2019 multidisciplinary analysis of BFHIs conducted in the US by Preston and Roeder and colleagues raised important questions about whether or not BFHIs and policies and initiatives like it are in fact mother-friendly, meaning do they consider the mother's interests and preferences? Taken together, where there is undoubtedly a positive impact of breastfeeding health promotion campaigns and education initiatives on breastfeeding outcomes, it is nonetheless important to consider both the costs of breastfeeding and the unintended consequences of such policies and initiatives. Kim will highlight the costs, and then I'll highlight some of the unintended consequences.
So since most of us here are public health nurses, researchers, or other professionals who work with postpartum mothers, I'm sure that we're all very well versed in the evidence that's supporting the numerous benefits of breastfeeding to both infants and mothers. So we just wanted to talk a little bit about the costs on balance, because it's important to mention some of the less discussed, but also legitimate costs that may come as a result of breastfeeding for some mothers. So I'm going to reference some work by Rebecca Kukla in the mid-2000s, and also Joan Wolfe and colleagues who did their work in the following decade. And they looked at and explored some of the more challenging implications for breastfeeding. So what was reported in these findings is that breastfeeding, and especially exclusive breastfeeding, can come at an enormous cost to mothers and families. Both of these authors had elucidated that these breastfeeding promotion programs in general often were failing to attend to the best interests of the moms. So some straightforward examples of such costs might include things like having one's sleep interrupted. And this doesn't seem like, like a big cost, but for some people, this can be, fairly catastrophic. Complications to return to work, for example, the extensive time resources it takes to pump. And even with some infants, just the actual time. So, for newborns, we're talking about up to 18 feeds in a day. So we want to make sure that we're mindful of these challenges. These are very real barriers for some mothers, depending upon their individual circumstances. In addition, and this is something that's maybe not so well discussed, breastfeeding impacts parenting and family life. So with the breastfeeding parent often responsible for the feeding, and this can potentially undermine gender equity, or it may be contrary to a parent's preferred division of labor in the home. So these are a little bit intangible or less than measured costs, but they're also fiscal costs associated. And so the data shows that breastfeeding 6 months or more, and especially if this is exclusive breastfeeding, is associated with more substantial and prolonged earning losses for the breastfeeding mother than for those that do not. And despite these well-established explicit and implicit costs, these factors had little to no role in the creation of the BFHI policies. So Wolfe, in her work, she's a critical feminist scholar. She asserted that this failure to consider breastfeeding costs to mothers is largely due to our deeply rooted normative conceptions of motherhood. So this is basically, where the good mother, with quotes, is defined as having behavior that reduces risks to children. But this is even when the risks are very small or poorly understood, but at significant cost to mothers. So given this, it's important to consider where a mother is at, and that she knows best what the costs are for her and for her family. So over to you, Tara.
Thanks. So on the cost, what about the unintended consequences of such campaigns and initiatives for mothers who don't breastfeed? The issues for mothers who don't breastfeed have been described in the literature as threefold. Kazitz Nova published a really interesting article in the Journal of Pediatrics in 2020, reporting that encouragement to breastfeed can be felt by mothers as pressure, which negatively impacts mothers, particularly those who are struggling with the decision to breastfeed. This pressure was then internalized by mothers as shame, which had significant impacts on their mental health. Second, BFHIs and campaigns such as Breast is Best and other initiatives are exclusive in that it leaves mothers behind, or it others them. Mothers left behind can include mothers who struggle with pain, low milk supply, injury, fatigue, work demands, illness, or those who choose not to breastfeed for a variety of reasons. Research has established profound negative impacts of othering in mental health, with the mother who recently commits suicide highlighting the most severe consequence. Work Kim and I have done with mothers has highlighted the impact of this othering in terms of internalized narratives that mothers hold, beliefs that they hold about themselves. Specifically, mothers we talked to who decided not to breastfeed held bad mother narratives that were typically harsher on themselves than if they were considering a different or another mother who decided to not breastfeed. And so these beliefs had impacts on their self-esteem, their self-efficacy, as well as the maternal decision-making. And finally, those who are othered or left behind are in fact done so systematically, as not all mothers are equally likely to breastfeed. Specifically, at-risk mothers, including those living in poverty and experiencing violence or other forms of trauma, are less likely to breastfeed compared to the general population of mothers. And this leads nicely into a discussion about sort of at-risk mothers. When we think about at-risk mothers, it's important to realize that this can be any mother. We tend to think of at-risk as a group outside of ourselves, and that just simply isn't true when it comes to experiences of trauma, violence, and abuse. It's important to realize that violence and abuse can occur at any age, in any culture, any religion, and any social location. Gender-based violence refers to harmful acts directed at an individual based on their gender. It's rooted in gender inequality, the abuse of power, and harmful norms. Gender-based violence is a serious violation of human rights and a life-threatening health and protection issue that's a significant public health concern. One that emerging evidence has indicated has been exacerbated by the COVID-19 pandemic. In Canada, approximately 1/3 of women experience IPV or intimate partner violence, which is a form of gender-based violence perpetrated by an intimate partner. 1/3. Every time I see that statistic or read that statistic, it really is staggering. Evidence has established that mothers who are experiencing violence might be one group that's actually at increased risk compared to sort of women broadly. Furthermore, mothers may be at greater risk for intimate partner violence during the perinatal period compared to other stages of mothering in work done by Campbell and Gazmamarian. Globally, estimates of this risk range from about 1% to a high of 21%. In a Canadian population-based study by Jensen and colleagues, they showed that physical violence during pregnancy was at about 6% in Ontario, which is among the highest of all provinces. However, it's important to realize that this work only encapsulated one form of violence, with notably sexual and emotional violence data missing. While this range is large and is likely means that it's fraught with issues in measurement, anytime we see those large ranges, it sort of calls into question some of the methodological particulars of a study. It's important that we focus on, or what we would like you to focus on, is the presence of an increased risk. This increased risk of violence for mothers has important implications for perinatal care, which Kim will discuss next.
Thank you, Tara. So now we're going to talk a little bit about the intersections, so between gender-based violence and intimate partner violence, trauma, and the perinatal period. So while this is not commonly discussed, the perinatal period can be particularly challenging for women at risk. And the unfortunate part about this is that perinatal caregivers feel generally unprepared to care for women who have experienced abuse, violence, or other trauma. So first and foremost, perinatal care in and of itself is invasive, and in some cases may be traumatic and particularly triggering. These reactions to care often come from feelings of being disempowered. So many aspects of perinatal care are medicalized, which may lead women to feeling increased feelings of powerlessness and vulnerability. So not surprisingly, there was a systematic review that was done by Misa Villa and colleagues in 2018, and they looked at breastfeeding among women who had histories of intimate partner violence. And they found that for these mothers, there were lower rates of intention to breastfeed, initiation rates, exclusive breastfeeding, and also a higher likelihood of early termination with exclusive breastfeeding when compared to those who were not living at home where violence was present. So this points to a need to think through how to best support these moms. There's some qualitative research in this area that we've done with mothers that indicated in many cases, the support and information that was being presented to moms was not matching their needs. And so the messaging around breastfeeding wasn't really accounted for in their experiences. Women with trauma histories present with a wide range of trauma-related sequelae, and these are not always obvious. And so, you might be thinking like mental health challenges, depression, anxiety, PTSD, and so forth. And for those who may not meet like sort of diagnostic criteria, there's many similar symptoms or partial PTSD just as an example. But regardless of the diagnosis, there are always these neuroendocrine alterations that are associated with trauma. So dysregulation of the HPA axis, including cortisol dysregulation, and these often interact with the neuroendocrine processes of pregnancy and postpartum. So as we all know, there are pregnancy changes that are physical and physiological, so increased heart rate, respiratory rate, shortness of breath, and so forth. Some of these physical sensations may be associated with anxiety, and for sure with PTSD, some of these sensations may activate cycles of arousal, hypervigilance, re-experiencing, and numbness. And in addition, the neuroendocrine changes that I just spoke about can impact the actual expression of PTSD. So this can increase the frequency, intensity of traumatic memories. And this has impacts on, we'll see it in mom's mood, her motivation, her cognition, sleep, and concentration, just to mention a few. So a few considerations to keep in mind with respect to trauma, violence, and breastfeeding. Partner support is instrumental in a woman's role, in her decision to breastfeed and with the success of breastfeeding outcomes. And the impact of stress from abusive situations can actually lead to physiological changes. So we know impaired milk letdown to the point of having inadequate milk production, and just maybe consider how a mother would feel in this situation. So she already has these sort of layers of trauma, being pressured to breastfeed, recovering from her birth, feeling inadequate or incapable because of these sort of physiological reasons that she has very little or no control over. So women in abusive relationships are less likely to successfully breastfeed. And in addition, as a result of this IPV-related stress, we're more likely to then have poor mental health outcomes. So IPV prevents barriers to breastfeeding. It's distressing due to the abuse. There could be a lack of partner support, or there could be actually active undermining by the abusive partner. So these and other obstacles have potential to severely undermine breastfeeding self-efficacy. So this leads us nicely into the idea of trauma and violence-informed care. And so we're going to be getting into the application of trauma and violence-informed care to breastfeeding practices. But first, we'd like to make a little note about the issue of screening. And I'm going to pass this over to Tara.
Thanks, Kim. So to screen or not to screen, that is the question. I feel like academics were a pretty calm, cool bunch. However, you get some IPV or GBV academics together and talk about screening, and it's about as riled up as you'll see us. It's quite a contentious debate, about as contentious, I think, as academics get in debates. So screening in the healthcare context means asking everybody, no matter why they're seeking care, about their experience of IPV. This often takes the form of a checklist. So just a set of questions like, have you ever been hit, slapped, or kicked? Have you ever been sexually abused, etc. The issue with this has been presented as twofold. One, many providers are not comfortable asking, and two, many providers don't know what to do with a yes. If providers aren't comfortable and don't know what to do with a yes, the efficacy of the screening is called into question. We all know when we're asked questions that people are uncomfortable asking, and how that makes us feel and how that impacts whether or not we're going to answer the question. Studies done globally have found that healthcare screening does not benefit women experiencing IPV. It doesn't improve their health outcomes or reduce violence experiences. Based on this evidence, the World Health Organization, the Canadian Task Force on Preventative Healthcare, and other groups do not recommend screening. In work done by Vega, led by Wathen and McMillan, it was found that while there is no direct evidence that screening harms women, we do know that starting a discussion or prompting discourse without systems of care in place to help women can in fact be harmful. We need to balance the harms of screening with the potential benefits to clinical practice. A 2021 review by Miller and colleagues found screening in healthcare could be effective as long as there's ongoing provider training, readily available referral resources, and consistent institutional support in maintaining appropriate IPV screening programs. That is a tall order in order to ensure that screening is effective. And so we need to really balance this idea of poorly done screening versus screening done well that's really supported by organizations to think about sort of what is the best option going forward. What Kim and I advocate for, based on the work that we've done, is using TVIC as a universal approach. And then we don't need to screen. Instead, work off the assumption that everybody has histories of trauma and abuse, and considering a third of women experience violence at some point of their life in Canada, and collectively society and all the individuals in it have just endured / are enduring a pandemic, the COVID-19, which is a collective trauma. This is not a far stretch. If we use a TVIC approach, we will be creating safety for all. And while this addresses an important gap for women experiencing violence, Kim's going to talk about how this universal approach might address other gaps in practice as well.
Thanks, Tara. So now that we understand that screening for abuse and violence is not the panacea we might have thought it was, we need to take a moment to think about the potential gaps in care, given what we've just discussed. So Julia Singh, back in the early 2000s, has done a lot of work in this area. And so, of course, we go to the literature and we see, so what are the gaps in care? And Julia Singh used women's narratives and experiences to describe the desired outcomes for, or sort of desired changes in health practices for those that were receiving maternity care who had histories of violence and gender-based violence. So participants in the study stated that they wanted practitioners to be aware of the impact of trauma. So not necessarily the details of what happened to that person per se, but what the impact was for them. So they would like us to assess for risk factors related to their perinatal outcomes. So, please do include talking about risk factors related to substance use. Please do talk about the risks related to my mental health. Please talk about safety, attachment, and these sorts of things. They wanted us to assume that PTSD is present. So basically, like Tara just said, if we sort of take this from a universal perspective, you're going to be avoiding triggering reactions. And obviously, under all of this, there's an expectation for a high level of care, comprehensive, appropriate care, advocating for appropriate programming, and ascertaining during follow-up if the care was sufficient, if what they provided was accessible, usable, and so forth. Now, misinterpretations, which often happen, of the methods women use to cope as a result of their trauma, often result in negative responses by the healthcare provider. This is problematic, and this is particularly evident in relationship to the woman's desire of control over her experience. So women have different needs for care depending upon where they're at with the trauma and the recovery. So this is why the trauma and violence informed care approach is a really appropriate means to caring for all. So now we're going to start walking through what trauma and violence informed care actually is and start applying these to real world situations. Over to you, Tara.
Thanks. So to understand a TVIC approach, we need to understand that context matters and influences how people respond to and how people make decisions. Policies, people, and relationships interact in ways that exert influence over people's lives. And what we're advocating for is an approach that can account for this and shifts responsibility from solely at the individual, but rather encourages people, community, and society at large to examine the roles that they're playing, whether intended or unintended. The graphic on the screen is from the World Health Organization Violence Prevention Alliance and represents an ecological framework that explains why some people or groups of people are at higher risk of experiences of violence. It's important to understand that the interaction between the factors at different levels heighten the risk of experiencing violence, as well as to think through how certain systems operate in ways to oppress individuals. The reason this ecological approach is important is unique to TVIC compared to other trauma-informed approaches to care is the emphasis on both historical and ongoing violence and their traumatic impacts. A strength of TVIC highlighted by Wathan and colleagues in 2022 was that it focuses on a person's experience of past and current violence, such that problems are seen as residing in both their psychological state as well as their social circumstances. TVIC also attends to systemic and institutional violence, including policies and practices that perpetuate harm to satisfy the needs of a system rather than those of a person. For example, if a mother decides not to breastfeed and then she has to retell every provider, that would be an example. TVIC also prioritizes the responsibility of organizations and providers supported by resources, policies, and systems to shift services at the point of care rather than having people work around services to get what they need. With this understanding, this is what we're advocating for, is a person-centered, trauma and violence-informed approach to care in breastfeeding practices. Kim's going to talk about how TVIC needs to be enacted both at the provider and organizational level.
So Tara just gave us sort of a nice overview of trauma and violence-informed care. That's a really quick snapshot. I mean, obviously, we have some stuff that we want to get into with respect to applying this. So we just sort of gave a very brief overview. But TVIC is a relatively new approach. Many of you have probably heard of trauma-informed care. This has been around for a while. And really what we're doing is we're expanding on trauma-informed care to also consider the impacts of systemic and interpersonal violence and the structural inequities in one's life. So this shift acknowledges the historical and ongoing violence and the traumatic impacts of a person's experience. So the next 4 slides, we are going to apply the principles of trauma and violence-informed care using these four headings. And it's important to note that trauma and violence-informed care needs to be enacted by both the healthcare provider and by the organization. And I know some of you are probably sitting there thinking, okay, well, I'm a, insert whatever role you are. And so I might not have control over what the organization does. So I'd like to invite you, to think about your role and how you can enact even some of the smaller or the more simple ways that we can enact TVIC in your practice, but also the advocacy part of it as well. So maybe kind of think about that as we're going through, and we'll of course be talking about examples. And from a provider perspective, so understanding that the experiences of trauma and violence may be affecting patients can help provide care in ways that make people feel safe. And the bonus to this for providers is that healthcare providers who practice TVIC report that they have higher morale and job satisfaction. So everybody's winning in this situation. And then from an organizational standpoint, so this could be a hospital, a postpartum unit, a public health unit, enabling trauma and violence-informed care is obviously going to involve policy. So creating or refining policies so they're effective in supporting TVIC. One such policy might be making sure staff have accessible training to increase their knowledge, awareness, and skills around TVIC. So if your workplace has supported you in being here today, that would be an example of one such policies. So over the next few slides, we're going to highlight some practical ways we can implement TVIC approaches alongside these principles. And as we go through these, it's important to note that they are often overlapping or intersecting. So over to you, Tara.
Okay, so the first principle of TVIC calls for building awareness and understanding. This includes awareness about the high prevalence of trauma and violence, which we've talked about in this presentation. Recall the higher rates of IPV in the Canadian, or the high rates of IPV in the Canadian population, and the increased risk for mothers during the perinatal period. It could also look like identifying the significance of historical, collective, and individual and ongoing interpersonal and systemic violence, including those groups of people who have been and still are systematically oppressed within healthcare systems in Canada. We could also apply this to the understanding that there are those who are systematically othered from breastfeeding, and thinking about ways in which we can shift policies to address some of those gaps. Building an awareness and understanding also means examining how the consequences of trauma can impact the perinatal period, specifically that intimate partner violence is more common than other pregnancy-related physical conditions, such as preeclampsia and gestational diabetes, which are routinely investigated during prenatal care and yet receive little attention within perinatal care, as found in studies by DeVries, Talio and colleagues, and Van Paris. Understanding it could also mean thinking through the wide range of adaptations people make to cope and survive with trauma and violence. This could include the decision to not breastfeed, as doing so may result or exacerbate the reemergence of PTSD or symptoms consistent with PTSD for survivors. Having an awareness of the relationship could also mean thinking through the connection of trauma and violence with chronic pain, substance use, physical and mental health concerns. These relationships are important given that childbirth in and of itself can be a traumatic experience for many women, and that there's a risk of secondary trauma that occurs for many IPV survivors. To build awareness and understanding, one of the things that we think is important is for people to examine their own experiences, your own power, and your own assumptions. It's that critical reflexive piece that's so important and paramount in nursing practice that we advocate would be a really great place to start in terms of building sort of out this first principle. And now Kim will talk about the next three principles.
Okay, thank you, Tara. So the second, I should say, principle is emphasize safety and trust. So as we've discussed, we don't need to know an individual's history of trauma or violence in order to perform or to enact trauma and violence informed care. So I think Tara had mentioned earlier, it's much like the concept of universal precautions. So we should universally be delivering this care in a respectful, safe way. And at the same time, though, we want to be trying to better understand the history and context of individuals and groups. So some simple and cost-free ways we can do this. And this is like, I'm thinking back to like year one, when I'm teaching students in the first year of undergrad, is really just extending respect. So just unconditional respect with a non-judgmental attitude towards mothers. And we do this by very simply establishing rapport and doing things like actively listening and responding to needs in appropriate and in a efficient way. We can also adapt physical spaces to maximize comfort and to ensure that these interactions, and especially in situations where women's bodies are being exposed, right, make them private. And also providing anticipatory guidance. So communicating clearly and articulately and accurately to mothers about what they can expect. Walk them through what's going to happen. Leave time for them to ask questions, and make sure that when you respond, you're doing so in a very honest way, but also with empathy. So when using a trauma and violence informed care approach, we want to ensure that we're not harming, traumatizing or re-traumatizing them. And ironically, I had a PhD defense that I sat in, and it was talking about how, adolescents were given birth. And one woman spoke about how the nurse basically slapped her in the leg and said, "You got yourself here, you can get through this," when she was moaning that she was in pain. So these are overtly traumatic things that we definitely need to be avoiding. And we can also demonstrate safety and trust by our interactions with our colleagues. So I've witnessed countless times in my practice where, a nurse or a lactation consultant is kind of like rushed in the room and started handling a woman's breast. Or it's in the comments that we hear. So these could be subtle or not so subtle, or aggressive or passive aggressive about, perhaps a woman's decision to supplement with formula. I've heard, "Oh, come on, you can do this. You're a grown woman," or "You push that baby out. Breastfeeding is not that hard." These are potentially traumatic statements that erode safety and trust. So we need to be mindful of language. It's a critical part of how we connect with humans, and it's one of the more important ways that we convey meaning. So, and unfortunately in perinatal care, it's fraught with medical terminology, which is problematic. So this type of language can be, very erosive or corrosive when it comes to building this trust and safety. So instead of using words like, say, non-compliant, we could use words like unsuitable care, or, "Oh, she doesn't want our help." We could use, "Our help isn't meeting her needs." Or, one of my favorites, pet peeves, is drug seeking. So she's seeking pain relief. So just these really kind of small but incremental steps forward really work to develop that trust. And this is how we're applying the trauma and violence informed lens. So the third way is offering authentic choices through connection and collaboration. So again, this just has to do with care options being meaningful, realistic, appropriate. And so this is where, we need to take women as they are and think about maybe their individual circumstances. So in some cases, the care that we're offering or the education that we're offering may be appropriate. But in some cases, what we're saying might not be appropriate in terms of accessibility or affordability. And, one of the things that comes to mind is, say if a person needed to return to work and they had to pump, there's costs that are associated with this, both, financially, but also the time that's involved in doing this. From an organizational standpoint, policies, they need to be flexible to allow for these shared decision-making opportunities, these collaborative discussions that need to be happening with our patients or our clients. We often make assumptions about what mom needs. And our best way to approach this is just by asking. So engaging in these discussions, these conversations, to really try to get to that deeper understanding. And in many cases, sometimes the assumptions that we make can be grossly incorrect. And these are those sort of potentially traumatic, not opportunities, but these sort of events that can happen that we can definitely be avoiding. I'm going to refer to Julia Seng again. So they conducted another qualitative study. And the women in this study stressed that they wanted their healthcare providers to name the distress, but not the abuse. So for example, if you're with a woman and she's struggling with, getting a latch or she's in pain, instead of making an assumption, you could say something like, it appears that breastfeeding might be causing some stress for you. Am I right here? Am I on the right track? And then just sort of opening that opportunity for discussion. There's no need to talk about trauma at this time. And they said it's also important when there's a longer relationship with mothers, if you're sort of having these sort of recurring visits, to ask them how they're doing every time you visit, and leaving genuine space for them to answer. So, and this is sometimes where I think we forget is we want to fill that space by talking, but just giving that moment of silence to allow them to think and consider, and so that extending that warmth and that rapport. And we can also enact trauma and violence informed care through our personal dynamics, being collaborative and warm and compassionate and so forth. And also, and finally, and most importantly, is asking permission to do things and giving the mother the most control. So the maximum control that you can extend in that circumstance. And then finally, building upon people's strengths. So we need to acknowledge people's journeys, but we also need to understand that there's effects of their past experiences, including trauma and violence on their lives. So it's important to identify and validate their strengths, to discuss how to build on for next steps. And for some women, the strength might actually be the fact that they've survived something. So every person that comes to us is going to have strengths, and it's up to us to sort of work with them to develop that therapeutic relationship, help to identify these strengths so that they can, sort of validate them and use them to move forward. So the programs and services that we offer should be tailored in a way that it can allow this flexibility to accommodate different needs and to support women on their journeys. If a woman has had, like I said, if they've had sort of severe trauma, we're talking about big T trauma here. Again, just remember that sometimes a woman's first priority is just surviving. So, I know we all tend to be, critical by nature. It's part of our, the human condition. So it's easier to see weaknesses first. So when a woman is sharing her experiences, actively listening, we can tune into these strengths. So the stories that she shares, and sometimes these are just things that maybe not related to, breastfeeding specifically, but other things that this person has sort of endured or has come out of stronger, and naming these and using these. And then one of the things that Tara and I found in our work with women was that, and where there was sort of a tension or maybe a disconnect with the healthcare provider, is sometimes mothers may not be articulating their needs in ways that would be, say, pleasant to receive. So if somebody's telling you, this is what I need, then these are the things that we need to tune into. Or if somebody says, I don't want a male resident caring for me, or don't touch my breasts, these are messages that we need to stay attuned to and sort of like, okay, let's explore this a little bit so that I can have greater understanding. So even for women who are far along in their trauma recovery, so they're knowledgeable about the effects it's had on their lives, they're advocating for themselves and so forth, to experience growth beyond their trauma, they do need to avoid triggers, and they do so by advocating for changes. And they also do this by articulating if they're dissatisfied. So again, we want to work to maintain as much control as possible over their aspects of care. So I've spoken a lot here. I'm going to pass this over to Tara. She's going to be talking a little bit about a fictitious case scenario where we can apply some of this.
Thanks, Kim. Can I get the chat pod open, please? So I'm just going to read a short case study because I thought maybe in the chat pod we could think through some of the ways that we could apply these principles. Kim and I have really just scratched the surface, and I feel like you guys are obviously significantly closer to practice than we are and know of maybe some things that you're already doing that are TVIC approached, or maybe already doing or tweaks to things that you're doing that could make it more trauma and violence informed. Or maybe they're big changes that are sort of the wish list that would help us to get there. So the case study is this, and it is just short, and you're welcome to sort of fill in the blanks in your own mind. So Faria came to London as a Syrian refugee. She speaks a little English. Aside from her family back in Syria, Faria's only support is her husband. She's a 2-year-old and has just given birth to a son 2 weeks ago. It's a snowy day, and she's taken 2 buses to get to the breastfeeding clinic that you're practicing at. She's 45 minutes late because she just couldn't remember the bus route. By way of a brief background, while her husband is generally supportive, Faria is pressured by her husband to breastfeed. Faria was sexually assaulted while at a refugee camp, and now every time she feeds her son, she has flashbacks to the assault. She didn't tell her husband about the assault and resolved to never speak of the assault to anybody. So sort of thinking through that case, I'm just wondering if in the chat pod, if you feel comfortable, if you could maybe think through one of the, some of the principles, any of the 4 principles of TVIC to apply that, what changes or what maybe we could do in practice to have sort of a TVIC approach with Faria. That tension between leaving space, and when you're a presenter, it always feels so big. But here we go. Oh my goodness, I'm always so encouraged when there's so much participation. Thank you. Absolutely. I think offering a home visit makes a lot of sense. That sort of really seeing where she is in that genuine collaboration that Kim talked about. I love that idea of asking about her goals for infant feeding practices. Again, a great way to collaborate with her and to really think through what it is that she would like. Oh, taxi chits. Yes. And I think that sometimes we think of TVIC as what can be done at an individual provider level, but it is an organizational response for us to remove some of those barriers, those structural barriers, that structural violence, those policy level or organizational level things absolutely do need to come into practice. And that's that stretch between trauma-informed care to trauma and violence-informed care. So yes, I think taxi chits are really wise, or absolutely going to Faria. Oh, I like that. The idea of a translator to support her in her language. Absolutely. I like that. Sometimes when we think about changes to practice, we get stuck in thinking about what are the things that I can control. I love that this group is really thinking beyond that, thinking about those more organizational level changes that would need to start, or that would need to be made. I'm trying to see, Kim, I don't know if there's any. I'm having a hard time keeping up because you guys are doing, it's so great. Sometimes in undergraduate education, you ask and nobody says anything. So it's really nice.
I love, they're so wonderful. I love, there was one that said, ask her about her feeding goals. That's a great way to open up the conversation to see, what is it specifically that she would like to see happen. Really sort of sets the frame for, that sort of openness, the non-judgmental attitude, supportive. So I thought that was just a really, really awesome comment.
Absolutely. I think to be honest, as I'm sort of screening these and reviewing them, they're all really amazing places to start. And I think I'm hopeful that in the responses that you're seeing in that chat pod, you can see sort of the intersection of how it is that these TVIC principles really overlap. We present them as distinct, but they really aren't. They absolutely sort of connect with one another. And so I think these are all really great ideas. And I love that you're focusing both on sort of individual things that you as practitioners can do, but also those organizational levels. So I think we'll leave that there so that we've got time for questions. So I'll pass it back over to Karen so that we can enter sort of the question period. So thank you.
Thank you, Kim and Tara. We're now going to move to the Q&A pod to address some of the audience's questions. If you're in the audience, please continue to enter your questions in the pod if you haven't already had the opportunity to do so. And before we begin, I just want to reiterate that the session's learning objectives were to identify the importance of a trauma and violence informed care approach in providing support to postpartum women and families, applying principles of TVIC or trauma and violence informed care when interacting with and supporting women and families in their choices of infant feeding, and understanding where to obtain TVIC resources for public health nurses and community-based professionals. I also would like to say that these slides and the references for the slides will be posted and probably be up. There we go. The information is right there in the chat. They'll be made available at that site. Okay, so we do have a few questions rolling in here, and I think I'll start with this question. What is the main challenge of trauma and violence informed care? When you're implementing it, how is it perceived by healthcare workers? And do you have an example of a success story?
Did you want me to field this one, Tara?
Go ahead.
I think this is just this is not going to be an evidence-based response, but I just think from practice and sort of thinking about, what I experienced in practice when I worked in perinatal care, but also what I hear from nurses, nursing students that are out in the field and so forth. I think systems are probably the biggest challenge right now. And which is why we're trying to emphasize today how when we're enacting TVIC, it's sometimes really in the small things that can have big wins. And this is where, we have to sort of take these little things as being, they're good and they're progress, because it's not like moving a mountain, but we are trying to shift things, and these shifts do not happen easily, and they take a lot of time. So, some of the things that we're talking about, structural violence, and some of the things that are in place now that sort of serve to perpetuate these sorts of problems are not going to go away. So we need to kind of work around them. And sometimes that takes creativity. And a lot of it has to do with leadership as well. Great leadership can do amazing things, even in these sort of structures that might be kind of running counter to us. In the work that Tara and I do with rural women in shelters, we see some really creative ways to enact trauma and violence informed care. I don't know if Tara, if you have a couple examples, not to put you on the spot, but this is just, it's not in the big things that we're doing. It's really in the little things that we're doing, and the advocacy, and just being there for women when, they just need somebody to listen and understand. And just that in and of itself can, you can see some amazing things. So.
Yeah, Kim, just to build off that, I think the biggest barrier that we tend to see with this is that the sort of systemic violence being addressed. But some of the greatest success stories we have are where there's inter-organization collaboration to create bridges back to healthcare for women who don't feel like healthcare is a safe space for them. Maybe they've had a bad experience in the past, and it's that interagency collaboration where, public health was working closely with shelters, so that shelters can say, like, hey, I know that nurse and she's fabulous, or they are fabulous. And it's that warm reception that helps to reduce some of those more systemic barriers where women might feel threatened to engage in healthcare.
There's a couple of questions here. Actually, one I think will follow nicely off of this, what you just spoke about in terms of the systemic issues being problematic. And if we remove breastfeeding supports and campaigns, how do we continue to reach parents who aren't most likely to breastfeed due to systemic systems of oppression?
Do you want me to start this one off, Tara?
Sure.
I think it's a great question, and really it's important to sort of underscore that we're not suggesting we throw the proverbial baby out with the bathwater. Public health campaigns are wonderful. They do help shift perspectives, and we've seen how that works. And we're not saying by any means that we don't want to be promoting breastfeeding for those that choose to do so. But what we need to recognize is that with the, say the Breast is Best sort of campaign, much like other health campaigns, they're targeting certain people that are often already in positions of privilege and who are educated and so forth. And it's the people that we're missing that we need to be sort of attending to in terms of like working, participating with populations and groups who are missing the information. So, like language was one of the issues that was just brought forward. So helping to develop things that are more maybe personalized or more culturally appropriate and things like that can go a long way as well. So I think it's just, like Tara, we kind of mentioned, we tend to paint people with the same brush, but really we need to sort of get into more of the nuances to make sure that we're getting the information where it needs to go, and that the people that receive the information are able to use that to make decisions that are good for them and their families.
There's another question here, and I'm going to maybe pick on Sarah here a little bit as well if she wants to help with this as well. But the question is about collecting stats, and one of the questions is, do we keep any race-based data on breastfeeding initiation in Canada? And a follow-up question to that is about somebody has asked about infant feeding surveillance systems and how can we collect data in a way that's trauma and violence informed?
I will attempt to answer that question. So I can't speak to all of Canada because, of course, our healthcare system is provincial, but I'll speak to Ontario. We do a poor job of it, is the truth. And I think since the past few years, we've gotten more aware of how poor we are at it, and in not just breastfeeding or healthy growth and development, but in all aspects of public health. It's become something that a lot more people are focused on looking at in a way to make it, equitable and to shine light on disparities in health, but also not just to shine a light on it, but to do something about it. So there's no reason to collect that data if you don't have a plan of action of what you're going to do with it, and of course of how you're going to present that to the communities that you're collecting, like racialized and marginalized communities. So that's kind of a broad answer to all kind of race-based data collection of public health. In terms of what's going on in infant feeding surveillance, since the BFHI in Ontario was removed from the standards, the accountability to collect that data for the designation has actually been lost, which is one of the sad parts about not having the accountability to do that. However, I know many health units are still maintaining their infant feeding surveillance despite not having having TUFA designation. And I think it's a critical part of all breastfeeding programs in Ontario is to do that, although I understand there are such challenges. And I'll pass it over to the speakers to talk about how to do it in a trauma and violence informed way.
Did you want to take this one, Tara?
Sure. I think when we're thinking about sort of the trauma and violence informed approaches, I think absolutely what Sarah's saying is bang on. If we're going to collect it, we have to do something. And if we're not going to do something, then we need to think about whether, in fact, collecting it makes sense. Because if not, we're actually just perpetrating and furthering that oppression, right? And I think we see this sort of over and over again in terms of intention versus execution. And that's where we really need to see sort of that shift at the organizational level to that embrace sort of that approach of the trauma and violence, that sort of big V violence, those systems that need to be better addressed. And shifting that orientation does require resources, and given sort of the resource scarcity that everything constantly exists in, it's about thinking about ways in which we can do that are meaningful.
Thank you so much. As we wrap up today's webinar, I would really like to thank Dr. Kimberly Jackson and Dr. Tara Mantler for presenting, and to Sarah Carsley for co-moderating with me. I also would like to thank everybody that joined us today for today's PHO webinar. The next one will be on May 10th, and it is Trauma and Violence Informed Public Health Practice, Language Matters, and registration will open for that early next week. You can expect to receive a brief and anonymous survey for today's session. Please try to complete this as it helps us to improve our programming. Lastly, to access past presentations and view confirmed and upcoming sessions, please visit PHO website, head to Education and Events, and click on Presentations. Thank you and have a wonderful day.